pediatric resident pediatric residency training at the combined programs of Boston Medical Center and Boston Children's Hospital. Andre has been involved in a variety of endeavors, and really a variety for a physician like myself during his early but very productive career. He served as a chief medical officer for Medicaid and CHIP services from 2016 to 17. He was actually appointed by President Obama and then served under President Trump's administration. And we were just laughing about this, where he lasted approximately 1 year. During that time, there were many efforts to try to dismantle, or I don't know if disable is the right term, of Medicaid, which he fought and advocated against. He might want to tell you about what happened at the end and why he left, but that's not the purpose of this talk. So he has practiced medicine here in Baltimore City, and he did addiction work. So he helped operate, even though he didn't practice there, he helped operate, and as we talked about, turned around the concerted opioid treatment programs in Baltimore, Maryland. And there's several that are operating in Baltimore City. He co-founded a software company, Carrot Hand, which developed a program that utilized a predictive analytical platform to prevent older individuals from being hospitalized. Currently, he is the managing partner of Social Innovation Ventures, which invests in and advises companies and nonprofits that are interested in eliminating disparities in healthcare. He also advises federal and state regulators on how to incorporate human-centered design into policymaking. So I'm going to introduce Andre. He's going to talk about utilizing telehealth strategies to decrease healthcare disparities.
Thank you so much. Thank you. Thank you for having me. I got my start right here during undergrad doing research in ophthalmology across the street. So I appreciate University of Maryland very much. I'm excited to be back, and I welcome questions, comments if folks want to interject throughout the formal remarks. I'll try to keep this to an hour and leave some space for questions at the end as well. And afterwards, if folks have questions or comments or want to hook up, just let me know. Very, very open to a dialogue here. I will be talking about telehealth and its use as a tool to close health equity gaps. I'll also broaden that aperture actually to include digital health more broadly. So there's some research that I think might be useful to you all that could hopefully help your patients. And with that, let me just make sure this guy's clicking. There we go. All of my financial disclosures are here. This is where all of my portfolio companies are. Everything I'm presenting here is actively published in a peer-reviewed journal or about to be published in a peer-reviewed journal. So with that, just take into account, and with a grain of salt, all of my comments. Learning objectives. So after this presentation, hopefully we'll get a little closer to understanding how to close gaps in care, especially in rural areas, but also we know beyond rural areas, there's disparities where technology can play a meaningful role. We'll hopefully be able to better increase access to healthcare for underserved communities. And we'll also look into some of the financial drivers, especially around social determinants of health and how that might play into or be supported by virtual modalities. So I'll start off with just setting some context around health disparities, and I'll offer you a lens through which I look disparities, which is a combination both of public health perspective and an investing perspective. COVID was ruthless. Over 1 million people have died. What's important, though, to point out, and I'm sure all of you know, especially working in a place like this, and I trained in a very similar institution up in Boston, at Boston Medical Center, the mortality and the morbidity around COVID was not equally distributed. Black and brown communities were significantly harder hit, and that is going to have ripple effects for decades to come. The thing is, COVID and the morbidity and mortality associated with it, it's just a symptom of a larger systemic racism issue. And that has implications for how we practice. That also has implications for how innovation can happen, has implications for how telehealth and digital health more broadly can be implemented, not to widen these gaps, but actually to close these gaps. A construct that was introduced to me a few years back, and I found it very useful in bridging the world both of public health and investing and looking through at a health equity lens. And it's this notion of the pyramid, and particularly the bottom of the pyramid. So Professor Prahalad out of University of Chicago in management science literature characterized, when you look at an entire market, this is from like a commercialization perspective. If you look at an entire market, there are folks at the top of the pyramid which have high purchasing power. Affluent folks, they can have disposable income to spend on fancy food or some app or a special service that maybe they cash pay for. That is not most people, certainly not most of our patient population. And as a reminder, I'm a pediatrician at an FQHC in DC. The populations I treat there are not at the top of this pyramid financially. So you go lower down the pyramid, especially if you look at the very bottom of the pyramid. The shape of the pyramid is meant to represent where the majority of the population lives, and that is at the bottom. It's the most voluminous part, but it's also the part where there is no purchasing power. The consumers have no discretionary money to spend on anything other than survival. And what Professor Prahalad made a very convincing point of, and he was referencing more so the global ecosystem, but this is very applicable to the United States as well, is that if an entrepreneur or an investor is trying to serve a market, it's very compelling to look at the top of the pyramid because people can spend money. But it's also actually very compelling from a total addressable market perspective to serve the bottom of the pyramid. There are a lot of people, they may not at an individual basis be able to pay that much money, in most cases can't pay much money at all. But there's Medicaid, we have our safety net there. There's Medicare, we have our safety net there. Exchange, we've got our safety net there. And so when you look at all of the folks combined and not to be crass, but the revenues that could be generated, it's actually very compelling from a market perspective. And I believe that is also where the biggest health equity gaps can be closed. So when we merge the investing and innovation space with public health principles and closing health equity gaps, the bottom of the pyramid becomes very compelling. Having said that, this is data from a recently published paper in Health Affairs that I wrote with a few colleagues from Stanford. We analyzed the top 10 funded startups in the serving the Medicaid space, and also the top 10 funded startups serving the Medicare Advantage space. In Medicare Advantage, those startups raised over $21 billion. In the Medicaid space, it was a meager 1.5 billion. Now, there's a lot of value to be created for sure in both spaces. Certainly Medicare eligible beneficiaries, folks over 65, it's important to serve that population, but Medicaid populations absolutely have needs. And from a financial perspective, while on an individual basis, if you look at the bottom row, and I apologize, the finance jargon and acronyms, but basically it's the profitability per patient. The column around Medicare, $45 per patient per month. Medicaid, $7 per patient per month. So on an individual basis, maybe not as profitable. Profits aren't everything, but even if they were everything, there are so many more people, and the market is so bigger in Medicaid. And given the public health emergency and COVID, the number of people on Medicaid has skyrocketed. Now, there's redetermination happening as a nuance. There's going to be about 50 million fewer people on Medicaid that are hopefully going to shift over to exchanges, but still the market is growing. It's big. And it's been growing even prior to COVID, so likely will keep growing. And if you look at the actual dollars amount, $427 billion spent on Medicare Advantage, but $734 billion spent on Medicaid. So this whole notion of bottom of the pyramid absolutely holds in the United States, just like it does outside of the United States. And I would argue that while it is hard for entrepreneurs to overcome the regulatory barriers, it's certainly worth it to serve these populations. And telehealth has to do with that in a big way, but other digital health modalities as well. So something to keep in mind. Talked about public payer space, but let me also touch upon a population that often is overlooked in terms of gaps in health equity, and that's commercially insured population. So everyone in this room, if you work here, you have insurance through your employer. That's commercially insured populations. And oftentimes it's a population that's perceived as, oh, there aren't health equity issues, or there aren't upstream health determinants that need to be addressed. When in fact, there are. The study by Para et al. In 2021 quantified several 100,000 folks that are commercially insured and looked at various things like their federal poverty level, as well as food access, which we'll get to in a moment. And what this represents is the red is folks that are less than 100% of the federal poverty level. So these are likely shift or seasonal workers. They are not making much money at all at the household level. And so there's a few red dots there. The orange is 100 to 200 of the federal poverty level. Look how prevalent the orange dots here are. This is a commercially insured population. This is in a band of poverty, even though that they have jobs and are commercially insured. And then there's a little bit of gray and a little bit of green, but even green, I mean, under 400% FPL, that's still, you're struggling really paycheck to paycheck. If we look at food access and food insecurity, the orange represents low food access. So quite substantial areas of low food access in a commercially insured population. In terms of the population that was searching for care by income, the blue represents folks with who are less than 200% of the federal poverty level, and the orange represents 400 and above. And the blue bars basically go way farther to the right than the orange bars, and it shows that people have meaningful needs that go unaddressed just in that going from 2 to 400 or 400 to 200% of the federal poverty level in a commercially insured population. So most of my studies, most of my work is focused on the public payer space. But if you all want to address health disparities, the commercially insured population is not immune from that. And one final angle, one final view of this is looking at the proportion of the population with access to key programs. So mental health, there was some meaningful access, but if we go down and look at childcare, getting access to food, as we talked about previously, transportation, meaningful constraints. Shifting gears in terms of setting the stage around disparities, I talked about income level, but there's also condition-specific disparities. And this data is from a study I did with a colleague of mine, Everett Crossland. He's on the board of the Digital Therapeutic Alliance. It's a nonprofit that aggregates a community of manufacturers looking at or creating digital therapeutics, so software as a medicine. And we dug into all of the FDA breakthrough designated devices. So these are devices that are deemed to be sufficiently innovative that they essentially get a fast track through the FDA approval or clearance process. And so there were 325 breakthrough designated devices. And then we looked at those devices that actually got approval or clearance, so about 10% of them. And then we dug a little further and looked at which of those actually got reimbursed by CMS, so Centers for Medicare and Medicaid Services. Now, this is predominantly Medicare reimbursement decisions. Again, Medicare 65 and older predominantly. And 2/3 of the devices that were approved or cleared got reimbursement. Not too bad. Okay, so if you get FDA approved, you're probably going to get reimbursement for the device you manufacture. But if we look at the gray bar, which is only seven devices, these are devices that were breakthrough designated devices that got FDA approval. So FDA said, yeah, there's plenty of literature to show this is safe and efficacious. But these were devices that were considered digital therapeutics or diagnostics. All right, so 7, about 1/3 of those that had ended up getting approved or cleared. Only one of those devices actually got reimbursed by CMS. Only one. So from a device category perspective, there appears to be a real disconnect in terms of the reimbursement construct at CMS, and I can elaborate on that in the Q&A. But here's what's worse. If we look by condition or system category, The colored bar to look for here is the dark green, or I should say the lack thereof of the dark green. So the dark green represents the breakthrough designated devices that are digital therapeutics or diagnostics that are reimbursed by CMS. And they are basically absent by category. Ophthalmology got one. So yay, ophtho, we're thrilled there. The challenge also to look at is if you look at the number of blue bars, the total number of breakthrough designated devices in the brain health space. So on the far left, behavioral, and then kind of on the right with neurology, there's not a lot of reimbursement relative to the number of devices coming out. And when we did an analysis of all the devices that get reimbursed, if you look at a somatic condition, 19 out of 20 FDA approved devices for a somatic condition got reimbursed. So heart health, GI, if you're creating an innovation there, you're probably going to get paid for that innovation. In brain health, it was only 30%. Who can maybe raise their hand and guess why that might be, or one of the root causes? Any guesses? How many psychiatrists do you guys think are employed by Medicare? 0. How many cardiologists do you think are employed as medical directors at Medicare? It's probably like 8 or 9. In Medicaid, so there's CMS, and then there's within CMS Center for Medicare, and then there's just Center for Medicaid and CHIP Services. CM, that's where a lot of these decisions are made. We've got a few physicians. In CMCS, there's 2 of us. There were 0 for a while. 0 physicians in the national Medicaid program to inform coverage decisions. No psychiatrists, no psychologists. That's one of the root causes. I think there's a general stigma against brain health in general, but something to keep in mind and a room for advocacy efforts. Now, this calls into question some ethical principles. We're clinicians here. We live and breathe by this stuff. I'm not sure if insurers always do. So there's the issue of justice. There's a very high risk of inequitable access with cash pay or even commercial insurance only. So if Medicaid or Medicare doesn't cover a technology that is shown to be efficacious and safe, it widens the equity gap, and it's a justice issue. Beneficence. So if the thing works, if we're intervening, it really needs to work and be effective. So when there's strong evidence for positive outcomes, we should, as insurers, be covering the thing. Telehealth and several digital therapeutic interventions have quite robust literature showing effective use and improved outcomes. And then doing no harm. So, Theranos, anyone by raise of hand familiar with the Theranos controversy? Yeah, Theranos snake oil. A bunch of investors basically had a big idea and then didn't deliver it, but lied. This is not that, right? If telehealth, if used appropriately, and prescription digital therapeutics, assuming they've gotten FDA clearance, when used appropriately, are quite safe. And especially in prescription digital therapeutics, with telehealth, there has to be appropriate patient selection and triage and all of that, but it's pretty safe. And so do no harm, that principle is met. Now, related to that, there's a study that I did with some of my mentees looking at telehealth, and in particular, coverage of telehealth after the public health emergency is over. So that's about to happen in May. What we did was we surveyed state Medicaid medical directors on their perspective of what should or should not be covered from a telehealth perspective. We got 10 folks to respond. It was a pretty quick survey. And these are the folks that are influencing the entire coverage landscape for a particular state. So it's a bit of a noisy slide, but what it represents is the dark blue. So on the left is support for both audio video as a modality and audio only. The slightly lighter blue, which there's only one case of that kind of in the middle, is only supporting audio only. And then the really light blue is only supporting reimbursement of audio video The yellow is not wanting to reimburse at all. So if we look at the band of light blue, there's a quite strong support for audio video. There's some moderate support for audio video and audio only. So some hesitation around audio only. And there's only a handful of CPT codes for which state Medicaid medical directors were actually reluctant to reimburse. This question was continued. It's basically just a longer list of CPT codes, similar trend there as well. Then we asked a different question, which is reimbursement for services that Medicaid beneficiaries generally receive by telephone. So dark blue, yes. Light blue, yes, with guardrails. And overall, the takeaway here is there is general support for telephone only intervention with patients. So guardrails emerged. There was a theme that there probably should be some kind of guardrails. Then we asked the question about interprofessional services, so basically e-consults. And there was general support for this. Interestingly, has anyone heard of the recent guidance from the National Medicaid program formalizing support for e-consults? CMCS just issued this guidance, and now if a state wishes, they can apply for approval to get federal match, so basically federal dollars to pay for their state Medicaid program to do e-consults, whether it's with a psychiatrist or some other specialist, where the patient doesn't have to be in the room with them. This is a pretty big deal from an access perspective, especially in areas with low access to specialists. And finally, we asked about the motivation for their decisions around coverage. And I guess we weren't really surprised that improving access to care, improving outcomes were a top priority for all of the respondents. Health equity was a top priority for 80% of the respondents. What is really interesting is if you look at the second from the bottom, in terms of the role of financial sustainability, only 30%, 3 out of the 10 respondents viewed that as a top priority. So it's interesting to see the clinician response where access and equity and outcomes are really important, but financial sustainability, let the CFOs deal with that. And that is a very interesting tension at the state level, especially right now. So key takeaways, overwhelming support for audio video, audio only with guardrails. In terms of interprofessional services, pretty strong support, some with guardrails, but now that's guidance. So that's already in flight and happening. And then health equity and access were top priorities, but financial considerations weren't quite as high of priorities. By raise of hands, is anyone familiar with the CPT 93 modifier? 1, 2, good. All right, excellent. Well, I'm glad I'm bringing this up to you all. So up until the middle of last year, each state had a hodgepodge approach to actually coding for audio-only telehealth. Some states use a G code, some states used a CR code. It was all over the place, incredibly hard to do health services research when you're not comparing apples to apples. So several state Medicaid medical directors and I got together, we advocated with the American Medical Association and got this CPT 93 modifier passed. So now there is a ubiquitous way across all states to track audio-only telehealth. My ask of you all is talk to your billing people to make sure that they update to CPT 93 instead of whatever is currently done in Maryland. I know that at my FQ down in DC, when I talked to our medical director when I wrote this paper, I was so proud of myself, came into the office, it's like, hey, we got this thing. And they're like, yeah, DC Medicaid, unless they tell us we have to do it, we're not going to do it. I was like, well, why is that? But it's all good. They are allowed to do it, but I understand the trepidation. And so I will be talking to our state Medicaid friends about this, but I figure I'd hit both ends of the spectrum here. So that's something to keep in mind. And for those of you looking for research projects, oh, what a great project to look at, right? Behavioral health, audio only, cost effectiveness, equity. There's so many great research questions to be asked. And we need that research to be done so that our federal colleagues and our state colleagues can see, all right, should we really be reimbursing at parity for audio, video, audio only, or in person? I have a bias, yes, especially for behavioral health, but please do the research and I'm happy to contribute. Continuing on the ethics trend. So there's there's a bunch of research supporting the use of telehealth, its outcomes, and in many cases, cost effectiveness if used appropriately. Same thing goes for digital therapeutics. And yet, the big national insurers are very conservative in terms of actually covering the thing that ethically they should be covering. So this is a very wonky micrographic example of a coverage policy at a large payer. I won't call them out, but you could Google it and you'll find who they are. Essentially, what it reads is something like this. For mobile software applications, MSAs, alluding to digital therapeutics, they basically say reasonable things, need to be FDA approved. Cool, great idea. There needs to be good evidence. Well, if the FDA approved, it's probably going to have good evidence. Fine. And then in the second criteria, it says, needs to be prescribed by a healthcare practitioner. Cool, yep, great. Patient-provider relationship. Bullet point point 2B, there's a point in here where it says, in accordance with generally accepted standards of medical practice. And the asterisk below basically says medical specialty societies have to deem this standard of care. It poses a bit of a challenge. Here's why. So the average time from when there's evidence until the time when a medical society actually says, yep, standard of care is, first of all, in many cases, we don't know about a third of the time, but then it's anywhere from 2 to 5 years. So you can have good literature, sufficient literature for the FDA to say, yep, safe and effective. But then for the insurers to say, okay, we're going to actually reimburse this for vulnerable populations. They're like, yeah, well, we need to wait for the medical societies, but the medical societies do not work quickly. And so we wait as long as 5 years or more to get these interventions that can improve access to populations in a meaningful way. This is another example of not just the slowness of coverage, but how coverage decisions are so inconsistent. So this is an example of an output from an insurance company going through a medical policy review exercise. And they describe how they went through HAYS, which is an evidence synthesizer. There's no data for an intervention. ECRI, up to date. I use up to date every time I'm on service. No data. Policy reporter, no data. And then they Google. So they find some press releases. And so these are all 1, 2, 3, 4, 5 interventions that got coverage. There are only 2 of them that actually have reasonable outcome data and FDA clearance. 3 of them, but several of them are run by friends of mine. I wish them the best. But why did they get coverage if they don't really have the evidence? They don't even have FDA approval. Why are they getting coverage? Salesmanship. Shiny object syndrome. It is a serious problem. I think, so we've got ethical issues here where if you've got really good salespeople that come into an esteemed institution like this and are like, hey, let me tell you how cool this is. And then boom, you get coverage because of great sales, not because of evidence. Or because the CEO often of an employer or an insurance company, they went to a talk or listened to a podcast and got revved up about something, digital thing about diabetes. Oh, I want that. And then they push it down and the folks underneath of them don't have enough pushback to say, well, maybe it doesn't have the evidence it needs to have. And so shiny object syndrome and the salesmanship, unfortunately, trumps, no pun intended, evidence in many cases. And that's something that has to be fixed. And so one example here that Propeller Health, which is a digital intervention for both kids with asthma as well as adults with asthma and COPD. This is just half of the studies that have been published. There's, I think, 43, 44 studies now. That actually has evidence. That has justification for coverage. The other solutions, by the way, I'm an investor in one of them, Learn to Live. I don't know if they should have coverage yet, right? They haven't produced the evidence yet. So this is a big ethical issue at the coverage level and a level of nuance that's really important when we think about access around telehealth and digital health more broadly. Okay, so digging into digital therapeutics. By raise of hands, has anyone ever used a digital therapeutic or know what they are? All right, no, okay, great. So level set, digital therapeutic is medicine that is here. So it's software as a medical device, typically an app that ideally goes through the FDA approval process. And there's a few now that have gone through that process, and you open up your app, you interact with it. Often the mechanism of action is some CBT-based mechanism of action. In other cases, it could be, there's a digital therapeutic around treating kids with ADHD that focus on the neuroplasticity around reacting to multiple stimuli. I'm still wrapping my head around the science of it, but it works. It's got evidence to show that it works. And then there's some other mechanisms of action that are super interesting, but it's software as a medical device. Instead of taking a pill, you interact with software. Category that the FDA has recognized, CMS hasn't fully recognized it yet. And I did this study with one of my mentees where we said, you know what, if the federal CMS folks aren't taking a lead, why don't we look to states? Maybe states where a lot of innovation often happens, maybe they have lessons for us around coverage for these innovative new technologies that are FDA approved with evidence, but we know there's a lag time until specialty societies actually issue guidance on standards of care getting updated. And so what we did was we reviewed 7 states' benefit coverage determination processes. These are states from across the country, red states, blue states, but all states that had some level of sophistication of streamlining their process. And we took those processes and distilled these 11 principles. I won't read all of them to you, but there are some that are really interesting. One is shifting the burden of proof that there is real evidence for the intervention away from the state Medicaid agency, which is understaffed, overwhelmed, onto the manufacturer. Let the manufacturer do the work of bringing all the literature together, packaging it nicely, and submitting it in its dossier to the state Medicaid agency. Another finding was having a more inclusive group of stakeholders in reviewing the application. In the state of Nevada, they do not have a single physician involved in this process. How is that possible? Okay, that's low bar. Higher bar is most states don't have beneficiaries, consumers, patients involved in the process. Why not? Let's make sure they're involved. What about community providers, not just a state employed clinician, but providers out in the community, providers in safety net settings, FQHCs, et cetera. So that was an interesting best practice. And then another insight was the more sophisticated states had scoring systems. So you get, certain number of points if you have really robust literature, you get like the most points if the governor asks for it. Very few states had points specific to health equity. That should be a standard where you get meaningful points in terms of do you or do you not get coverage if there is actual evidence showing closure of health equity gaps. Now, if you're serving the Medicaid population, overall, you're probably going to be closing health equity gaps, but there's still heterogeneity within Medicaid populations. And so those are some of the findings there. And then we offered some examples of benefit, like actually how would coverage happen. I won't go through all these because I don't want to have you all fall asleep before patient care. But the point is there is precedent already. There is some coverage, and this paper highlights those examples. Okay, changing gears a little bit. I'm going to step away from digital and just go to bread and butter services to highlight that I believe the holy grail is value-based payment. If we get to full risk onto providers and they're well supported, partnered with community-based organizations, we fix all of the things that are broken with healthcare, basically. And what I want to highlight to you is it is totally doable. And if it can be done in the ABA space or in the treatment of autism space, it really can be done anywhere. Because that is a space that providers are often under-resourced. They do not have tech. They do not typically have sophisticated operational processes, but it is totally doable. So 3 quick studies. A different set of colleagues from Stanford and I wrote this paper in JAMA that quantified what I think is obvious to all of us that work with kids, and that is there are meaningful racial and ethnic disparities in treating kids with autism. And we have some nice visuals that show where the deserts are in treatment, stratified by race and ethnicity. So a very policy amenable paper. But this is just to plant a stake in the ground to say huge disparities exist in diagnosis, especially by race and ethnicity. Separate study, this happens to be a poster, I think represents the data all in one place, but we ended up publishing this in Nature. What it showed was that you can apply artificial intelligence to a technology that can have comparable performance characteristics in diagnosing kids with autism compared to a human, but unlike a human, is not going to have discrepancies or differences in race or ethnicity or in socioeconomic status. Think about that. This is a rare instance where AI is not perpetuating disparities, but actually decreasing them. Functionally, as a pediatrician, what does it mean for me? Right now, if I screen a kiddo, MCHAT or otherwise, if I have concerns, I refer them. If I pray enough, they'll be seen in 9 months with a diagnostician, and they'll do an ADOS and they'll get a diagnosis, and then they can actually start services. That's 9 months, 9 months of no services in the most critical period of time. With this technology, within a matter of days in a PCP setting, you get a diagnosis. Yes, determinate. No, they do not have ASD or indeterminate. And 1/3 of those kids come back indeterminate. So fine. The waiting line, instead of being 9 months, we cut that by 2/3. Maybe it's only 3 months or 2 months. So I get very excited about this because of the potential to really close health equity gaps and actually walk the talk of AI potential, and not just like Chat GPT, Van Gogh picture of whatever, I don't care. So this is really meaningful. The reference to the study is down there. Okay, now I'm gonna take a step back from my excitement. If I put my insurer hat back on and I think, I have limited taxpayer dollars. Medicaid budgets are already strained. A kiddo with an ASD diagnosis is going to cost anywhere from $50,000 to $60,000 a year to treat in our current paradigm. That's a lot more kids that cost $50,000 and $60,000. We don't have the budget. And what functionally happens is you have well-intentioned policymakers and maybe less well-intentioned people at the insurance companies that are like, autism? What autism? And they just ignore it. And they say, yeah, sure, we're diagnosing, but they do not go out of their way to screen and diagnose, even though EPSDT, a mandatory benefit by law, they have to be doing it, they're not doing it. So this actually sets up a bit of a conundrum for us, because now we have the technological ability to enable every primary care pediatrician in the country, or family medicine doc, or family medicine provider, or whatever, primary care person, to diagnose kids within days, but insurers are afraid it's going to cost a lot. And they're justified. It's going to increase costs probably in a meaningful way. But I believe there's a solution. The third study. So this is a study we published in the World Journal of Pediatrics. One of my mentees, who's now a UCSF intern in pediatrics, Ted Cho, love him. He was the lead author. We looked at a sampling frame of data from an ABA provider out in California. I'm an investor in that provider, so again, take this with a grain of salt, but I invested in that provider because they were doing something unique. They were tweaking their care plan every single month. They were getting, like we know is standard of care, but it's unfortunately not a standard that's followed in the industry. The care team, the kiddo, the family get together every month. They look at an objective measure of function, the Vineland score, imperfect, but at least it's measurement-based care. And they say, is the kiddo progressing? Yes, no, tweak the plan, iterate, iterate, iterate. And by doing that, as well as some interesting process and organizational cultural principles, what we showed is the following. They had statistically and more importantly, clinically significant improvement in outcomes, the top chart. So these are the composite Vineland score measure of function. And then there's certain domains around communications, daily living, socialization. So generally improvements in outcomes. But what the second chart below shows is if you look at more than 40 hours a month, not a week, a month, versus less than 40 hours a month, the kids still got better, but there were no differences. So kids get better, outcomes get better independent of the number of hours of services. This goes in the face of what my specialty society says should be standard of care, which is any kiddo we diagnose with an ASD should get a minimum of 100 hours a month. And I spoke with the folks that set that guidance, and they were like, well, we don't really have a foundation for that. We just didn't want insurers to cut the kids off from services. 100 hours a month is what has gotten us into this issue of kids costing $50,000 or $60,000 a year, because you get private equity people, investors who buy these ABA providers and are like, ratchet up the revenue, go, 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 without thinking, well, what's right for this kid or what's right for the patient. And so what has this led to? This provider, Kaio, and an insurer, Magellan, have established for the first time in the country, a value-based payment arrangement for ABA. So the insurer is basically saying, oh, great, I know I'm never going to pay more than whatever, 40 grand a year or 30 grand a year per kid, as long as I preferentially refer to this provider. So it's basically cutting the costs in half. Kids are guaranteed access to services. Now, if we tie all three studies together, give every kiddo a chance to get diagnosis early in an equitable way, but don't give a panic attack to the insurers that that's going to open the floodgates for unlimited spending, but rather tie all providers into value-based payment arrangements, which is a big feat. There's a lot of change management that needs to happen, but it can happen. Now you have a virtuous cycle where you get everyone access to care, early intervention. In some cases, kids will get treated out of the diagnosis, and taxpayers aren't going to go up in arms because we have unlimited spending. All right, almost done here. 10 more minutes and then we'll go to Q&A so folks can skedoodle at 1. I'll be around obviously for 1:30. Okay, so we talked about telehealth, digital therapeutics. We talked about value-based payment is possible in the most impossible setting, ABA. So it must be possible for incorporating telehealth or digital as well. But now we need to talk about how do we broaden the use of digital modalities to address social risk factors? And there's been a lot of buzz over the past few years about SDOH this and SDOH that. It's become cool to be an expert in SDOH. The problem is if there's no money behind the thing does not get done. And last year, I worked with friends from the American Board of Family Medicine Foundation with some very generous funding from Commonwealth Fund and Arnold Ventures to fund the American Board of Family Medicine Foundation. I volunteered my time to facilitate this stuff. We had 2 workshops. One workshop was focused on Medicare Advantage. One workshop was focused on Medicaid. We got 20 folks from across the country representing payers, providers, consumers, community-based organizations. And we sat down for a day and literally thought, what is the ideal state of paying for social risk factors and actually adjusting payment for social risk? And so I'll share with you some of those outputs. I won't go into all the details because it may cross your eyes a little bit. The outputs were accepted for a paper in Health Affairs. I'll send that out as soon as it's available. But there is a publicly available synthesis document, 19 pages, great read, that goes into the details of how to operationalize these things. And one thing I will point out is right now, the way insurance companies get paid more, and this is across all insurance types, Medicare, commercial, Medicaid, is if they send someone into the home and proactively discover that that person has not just arthritis, but arthritis and heart failure, that patient goes from, if it's Medicare, they go from like a $1,000 a month patient to like a $1,500 a month patient. It's a big boost in revenue for them. So they're very financially incentivized to go detect what somatic conditions, typically somatic conditions, behavioral conditions as well, do they have. There is no financial incentive to go figure out, are they homeless? There is no financial incentive to figure out, are they hungry? And this workshop looked at how do we actually get insurers the money to pass through to the community, pay providers more for treating folks that have upstream health determinant needs. So a couple cool findings from the Medicare Advantage workshop. I'll just highlight number 3 here. This is such an interesting insight and I think fascinating. And I don't know why it's surprising. I feel like I should have known better. I should have known, but it was a bit of an aha moment. We had patients, beneficiaries basically say, all right, cool. Yeah, I get asked all the time about my needs around transportation or my needs around hunger. But if you ask me if I'm hungry and you don't offer me food, I'm done. That's rude. It's mean. It's like pouring salt into the wound. And all these insurers, and we had like chief medical officers from the big four national insurers are like, oops, mea culpa, because they're doing all these SDOH surveys. That's a big fad now. SDOH survey this, SDOH survey that, but none of them have interventions to follow up those surveys. So it's an ethical obligation that these patients brought to our attention. In the second workshop, also some just wonderful findings. One neat finding, honestly, was that if social risk factors or social interventions are being done, they should be paid for out of the medical loss ratio. This is very wonky. I acknowledge some folks may not be familiar with the MLR, but basically what it says is social interventions should be treated just like an intervention like you're going to see a specialist, as opposed to eating out of the profit margin of the insurer, which allows it to be a little bit more scalable. And related to this workshop, and I'll wrap things up here, separate body of work, this literature is in peer review, not published yet, but what we did was we looked at some colleagues of mine from a organization called Customer Value Partners. They have access to all Medicare data from the past decade. We looked at a pre-COVID 1 year sampling frame of 30-day Medicare readmissions. And we correlated that with something called the Social Deprivation Index, or SDI, publicly available data, census data used to determine social risk. So SDI towards 0, really affluent area, Roland Park. SDI 100 is East 25th and Greenmount, where I used to run a series of opioid treatment programs. And what we found is, so prior literature said that if you're less than the 4th quartile of SDI, the higher your SDI, like, it doesn't really impact your outcomes. What we found is actually any incremental change in SDI increases your 30-day readmission risk. So especially for folks in middle-class areas, SDI definitely can predict readmission rate, especially marginal increases. But once you get into the 4th quartile, it starts to get exponential. So any incremental increase in social risk has an exponentially increased risk of 30-day readmissions. So this is something that can actually be productized. You can build technology, you can build interesting solutions around this. More importantly, insurers, government can more precisely pay and know exactly how much to pay if they want to prevent a readmission based on social risk factors. You can derive that from these data. So tech is fun, tech is great. Telehealth, great improvements to access. If we don't tie it all back to payment, it's never going to scale up. It's never going to scale up. So that's the key takeaway here. With that, PHE is ending. We have until end of 24, until everything turns into a pumpkin and the flexibilities go away. We've had the DEA, as we talked about before the session, issue some very concerning guidance that really limits access to treatment for many folks with behavioral health conditions, but we can do something about it. I wrote an article that highlights exactly what we all can do. And if anyone wants to collaborate or get guidance or template letters of comments to submit to DEA, comments to submit to CMS, at this point, it's a legislative fix. We need to be going to our Congress people and saying, we demand this for our patients. Happy to volunteer my time to help do that. With that, happy to take questions. Thank you. Any questions or comments? Dr. Marcosi, good to see you.
From the operational, financial construct, there's more of a strategic one. In your view, is it not that our nation's best interest, but social determinants will help? The challenge we have is how can we actually think through the impact of bus routes and civic responsibilities. And as we walk into the world of healthcare financing, also we did, and healthcare then needs to understand what is the tax base and revenue for a city. How do we embrace this kind of uniformity? And one question I had is, you and I and others in this room is, are we going about this one?
That is a great question. Oh yeah, so the one-liner of that question from the esteemed Dr. McCosey is, should we be using healthcare dollars to pay for social interventions? And this came up in one of the workshops and came up for like an hour. And one argument was that using healthcare dollars to pay for something like housing is a very inefficient way to pay for housing. HUD, for example, has very efficient, not the best working, but they're very efficient paths to using taxpayer dollars to get housing. But to send taxpayer dollars through an insurance company that's going to take at least a 15% cut of those dollars before they pass it on to housing. Ooh, I don't know if taxpayers are thrilled about it. 15%, like let's pay some insurer VIG, if you will. The other point, counterpoint to that, which I think a lot of state Medicaid colleagues consider, is if we don't pay for housing, for example, that patient's going to end up in the ED anyway. That is going to hit our Medicaid budget anyway. So it's not our choice. We don't have the luxury of deciding, well, which patients are or not going to end on our P&L. They're going to end up in the ED. That will be a coster. So even if it's inefficient to spend dollars from healthcare on social needs, there's really no better way yet to do it. So what we concluded from the workshop and what these data offer is, here is actually a precise way to target those dollars in a payment mechanism that would not necessarily overspend so that every insurer gets a ton of money, but rather let's spend those dollars, not get them stuck and held up at the insurance company, but pass it through to the community at a neighborhood level, not a zip code, but a neighborhood level. So I think there is a path to doing that well. Maryland obviously is a whole different ball of wax because of the payment model. But outside of Maryland, I think this may be simple enough. In Maryland, we should chat. How might we improve that? Any other comments or questions? Yeah, don't be afraid. You got it. I like controversial. Let's do it.
But so telehealth, fabulous. And there's probably no better area to do telehealth than mental health than addiction. That said, there's been this, I just wonder what thoughts you have about this, but there's been this trend of, our patients have gotten very acclimated to sit in home, get on the phone. And yet that is not always the best delivery. Do a comprehensive evaluation to really understand what's going on with the patient. I've been sitting in meetings recently with many other disciplines where the push is they don't show up just to a telehealth visit, but really have to do a complicated full neuro exam on the phone or evaluate TB on the phone. But is that the best work? And is it okay that we haven't seen someone in person? I just think it raises all kinds of. And now, I mean, we all, I'm sure, have patients that refuse to come in. They just want to see you, and maybe they'll turn their camera on and then you go home. And so, I hear patient satisfaction and give patient like their time, not necessarily. I don't know. Is anybody paying attention?
A lot of people are paying attention to that. And I think the hesitation you're expressing is highlighted in these data right here, right? There's not a lot of audio only approval. There's literally only a couple of medium blue snippets of state Medicaid medical directors saying, yeah, sure, audio only. But I think the constraint they experience, and probably the constraint you're experiencing, is the system in which we are allowed to practice. I would argue, why shouldn't we have a full neuro evaluation in the patient's home? Maybe it's not all virtual. Maybe it's part virtual, part send a lab tech to the house, part, in some cases, send a physician to the house. Or maybe it's not a physician, maybe it's an EMT with a physician audiovisual. I think there are, with the help of virtual modalities, ways, if we redesign our internal processes and how we're paid to meet the patients where they are, where they can get which is absolutely delightful experiences, and the system can make money, maybe not huge margins, but make money. And that comes back to the example I showed with ABA. Like if an ABA provider can figure out a way to go financially at risk, I bet we can figure out in other settings to go at risk in a way that really allows us to creatively change practice patterns. And that really comes down to full risk. Yeah. Hi. Hey.
Hi.
Good to see you. How are you? It's a long time.
Because I feel in my practice that telehealth in telephone only has been beneficial in terms of having the student.
Mm-hmm.
I think what hesitancy that I have is, does it actually change the outcome? Does it show that data show that how do we create a connection to improve optimization? Suicide and race. Do we have any good data to suggest that, or are we still needing to collect the data?
The data, I believe, are variable. I think there's some studies that show like a pretty good effect size. The study designs of those studies are not the best. And that's the constraint. And so, oh, come on in. No, go and hang out. We definitely need more research. And at the same time, I think we need to ask ourselves the question of what outcome measures are we using? I think it's totally valid to look at high cost outcomes, emergency room utilization, inpatient utilization, recidivism. But another group of outcomes I think that are very valid and mean more to the patient a lot of times than ED inpatient, patient reported outcomes. Are they meeting their goals of care? And NCQA has done some pretty pioneering work on standardizing frameworks around how to measure patient reported outcomes, especially around goals of care, such that it is an apples to apples comparison, because your goals of care and my goals of care may be very different. But if we are having our goals met, or more importantly, when they are not met, ensuring there's a quality improvement process put in place, I think that's a really neat area of research exploration that needs to happen, and like yesterday. And I would also add that there are, if folks are looking for very specific, oh, cool, there's questions on here. I'm going to see if I go to these questions in a second. There are recent codes, CPT and HCPCS codes that have come out that could be awesome grounds for just like claims mining tied to patient-reported outcome measures. And I can elaborate on that a little bit later, but some of the digital related ones, there's like A9291 or something like that, HCPCS code for prescription digital therapeutic for CBT. There are the remote therapeutic monitoring 98975 or whatever for, it could be used for like medication adherence or response to virtual CBT interventions. Like that is a whole very ripe area. There's policy amenable health services research. And if anyone ever wants to brainstorm research questions, please let me know. Also, for what's worth, I'm on the board of NIDA. If there's addiction related questions, they want research applications. Like I am happy to help frame up like how NIH and NIDA in particular is looking at reviewing these applications. And also great to see you. Thank you for the question. Any other questions live before maybe I try to see if I can do a Zoom one? Any live? Okay, let me see. So there's a question from Stephanie Knight. I was recently asked to represent the Maryland Psychiatry Society for our Carrier Advisory Committee for Medicare. The group ultimately recommends coverage of services and products. I think you're right. It's a struggle to understand acronyms, let alone committee infrastructure, processes, and expectations of members. A lack of transparency is a horrifically effective way to keep concentrated power in the hands of the few. Amen, Stephanie. I agree. If I can ever help demystify acronyms, I'm at your service, Stephanie. I think you can get my contact info from Anna or any of the organizers. Any other in-person comments or questions? There's one more three-part question here on Zoom. But before I read that, any comments or questions here? Okay, cool. So we've got Aaron Greenblatt that talks about evidence seems quite thin for some cleared and reimbursed digital therapeutics, which I have been target of aggressive marketing. Oh, well, I'm sorry to hear that, aggressive marketing. Perhaps not out of line with other reimbursed interventions, but one, how do we ensure that entrepreneurial enthusiasm for digital therapeutic interventions doesn't outstrip effectiveness measured by patient-oriented outcomes? Oh, that's a good one, Aaron. I think the medical policy review process at the insurer level should be the mechanism. Hey, Aaron, I see you now. Should be the mechanism of doing that. The problem is that the medical policy review process at the insurer level depends on some of the evidence synthesizers that I pointed out earlier. So like Hayes or UpToDate, and those synthesizers, I've spoken with their leadership, and unfortunately, they're very regressive in terms of their view on technology. I think it has something to do with who they employ. I don't think they necessarily have a bunch of digital native millennial clinicians that are in there. I think it's only one of the root causes, to be honest. I also think that in some cases, it is a pay-to-play role for the evidence synthesizers. So if you're a manufacturer and you pay a ton of money, then you get your thing reviewed faster. And not a lot of manufacturers have the resources to do that. I will call out that OHSU has a Medicaid policy evidence process. So they review evidence around technology innovations and offer guidance to states. And I think they do quite a good job. The thing is, their sensing function is not rooted in where technology and innovation lies. And so I think the evidence synthesizers need to beef up their efforts to look at the technology-driven or tech-forward interventions so that you, Dr. Greenblatt, don't have to suffer marketing angst from these folks and, decide like, do I trust this detailer or not? But rather just go to UpToDate and be like, oh, cool, UpToDate says this or Hayes says that. I think that is ultimately the holy grail. And I mean, I honestly don't have a whole lot of hope for medical specialty societies to hurry up. They're just like, I don't know, they've been really dragging their feet, but it's a real issue. I think it's to the shiny object syndrome, and it gets to the salesmanship issue. And those are ethical dilemmas. Any comments or questions, Aaron, you have on that? I don't know if you can go off mute.
No, I think the shiny object is kind of the salient point here.
Yeah. Awesome. Thank you for that. Aaron has two more parts to his question, so I'll jump into those. But before I do that,
You don't have to
other
answer all of them, but I appreciate you looking at them.
Oh, thanks, Aaron. I appreciate it. No, this is great. I love them. Any other comments or questions from the room? All right, the room is expert on this stuff, so we're going to come back to you, Aaron. No, Aaron, you actually seem very expert on this, so this is great. So Aaron's next question was, do you have any concerns regarding digital therapeutics affecting behavior change through surveillance rather than through autonomy support? Oh, Aaron, I'm going to defer to you on that one. I love that question. I don't know. Can you elaborate on the distinction of autonomy support versus surveillance, and do you think one is better than the other?
I think autonomy support is what I think we're all going for. We're trying to help, especially in this setting of substance use disorders, we're trying to help people reassert and reestablish autonomy in terms of their decision making. I think a lot of what I do as an addiction provider, though, we end up doing the kind of easier thing, which is just forcing people to do what we think they should do. And at the ATOD meeting, a lot of the supervised dosing, asynchronous
Mhm.
video monitoring of medication adherence. We can cast that as supporting people in terms of their medication adherence, but on some
Mhm.
level, it seemed like we were just extending our reach of how much we can control people's behavior. And I'm tempted by that, but I'm also very uncomfortable with it.
Yeah. And I think it's a great point. And what that brings up for me is this initial excitement, but then slight disappointment I had with implementing contingency management, just like old school contingency management, no tech at all. And in my experience with a concerted care group across town, we implemented contingency management, and the mechanism we used for reward was bus tokens. And so when folks were compliant with meeting certain goals with their treatment plan, we gave them bus tokens. It worked really well until it didn't. And what I mean by that is, just like published literature has shown, when you remove the reward, you regress to the mean in behavior, and sometimes even dip below the mean before going back to the mean. And so I think it was great that we were able to get people closer to recovery. And honestly, as long as the resource is there, I would give infinite bus tokens away if it kept people, even superficially, even through surveillance, from relapse. And I think what it does, I'm not a psychologist or psychiatrist, right? I'm a pediatrician, so I'm gonna defer to you on like mechanistically. But what I think it offered the team there, and maybe this by extension goes to remote therapeutic monitoring or digital therapeutics, more of a window to get that trust, get that patient activation, and then the motivation to actually have the autonomy and autonomously driven change. I'm just speculating though. I would defer to you guys if that's like valid. What do you think, Aaron?
Still learning.
Yeah, I like that. All right. Before we go to Aaron's third question, we should make this a blog post, Aaron, by the way. We should just, oh, please.
Again, feel free to dismiss it.
Yeah, no. This is great. We got Rob, go ahead.
So just a comment. It does seem like in this arena, we are moving forward technology and program design and video conferencing and digital, et cetera. When for basic needs for patients are things like housing
Mhm.
and food and safety. So they get caught up with these more advanced kinds of methods, but we haven't fixed the floor. What are your thoughts about that?
I think you bring up a great point, and I would go back to the workshops around social risk and risk adjustment. If the Maslow's triangle found, the base isn't addressed, we could do all the adherence, compliance, fun tech stuff, and it doesn't matter. And all of that then comes back to how healthcare is financed. And as Dr. Marcosi alluded to, planting, he knew exactly what I'd say. But I think if the system of provision of care is financially incentivized to make sure the housing happens, housing will happen. If a provider is going to make more incremental profit margin from that, they will go and do it. If they're not financially incentivized, in the end, it's like even our best intentions, we're going to hit system blockers. And the issue is we can't depend on our individual ethical compass. We have to have the systems supporting our ethical compasses, or whatever the plural of compasses. But I think that's what it comes down to. And until that gets addressed, then technology or technology-enabled services are only going to get just a little bit of lift for us. But I do think that they can get a lot of lift as part of a broader care delivery model. And we're starting to see that with some of these technology-enabled service providers. They by default are taking financial risk. And I think that's a very interesting trend. And I think they will start to eat into market share of incumbent system. They are eating into market share of incumbent systems, which is cool. Cool to see. Any other questions or comments before I go to the Aaron and Andre show? I love this, Aaron. We should do a podcast. All right, Aaron, the third question, these are excellent questions. Policy question. The risk payment adjustment framework with ACA plans was sabotaged by established, deep-pocketed for-profit companies, driving newer nonprofit health insurance co-ops out of business. Among other things, established companies use the advantage of a longer period of accumulated data to demonstrate that their patients were sicker, quote unquote, sicker than newcomers who had to collect the data de novo. How do we broaden participants' innovation in the insurance space? Ooh, yeah, I love that question. So there are some new entrants insurance upstarts. They're mostly focused on the Medicare Advantage space, which is great. They need innovation there. The problem, as I mentioned, I don't know if I mentioned here or in our earlier session, but there's pretty consistent literature showing that private equity involvement in healthcare on average worsens outcomes. And now it's specific to nursing home literature and home health literature. But I totally get it. I mean, I see it. I sit on a couple boards with private equity investors. They're great investors for what it's worth, the ones I work with. But I believe there is opportunity with sufficient investment to compete. I believe these new upstarts, these tech-enabled insurers are competing effectively. And what I think is yet to be shown is how do you do that not in the Medicare Advantage space, but in the Medicaid space. With Medicaid, the unit economics, like a per person profit margin, as I showed, is much lower. And so it's a longer time to get to profitability, and maybe the profitability isn't as robust. So, and there's just frankly stigma against Medicaid populations. But I do think it is doable. I think it is a very ripe space for investment. There is one company I'm looking at investing in that's kind of heading in that direction, but I don't know them well enough to be able to like green light and champion them. But I think it is doable. And the real challenge then becomes, Aaron, is you get one of these startups, they are implementing an effective strategy, they're ethically and mission oriented, but then are they going to just get gobbled up by Optum and become irrelevant again? And that's the real challenge. But I do think it's doable, and I would bet my money that there's going to be a few that really break through and do it in an interesting way. How's that, Aaron? Do you agree with that? Oh, you're welcome. Cool. All right. Any final comments or questions before we wrap up? I think we covered all of our. Yeah, we got all of our online questions. Cool. Well, if anyone has any questions afterwards, I'll stick around for 10 minutes or so. And then if anyone is starting a company, please give me a shout. If you need any input career-wise, at your service. And Dr. Greenblatt, let me know about the podcast idea. Thanks, everyone.